Try
With
again,
that, why don't
Stuart.
we go on to Tim? Yeah.
Yeah. Okay. So can I have the first slide? This is actually a really interesting thing. What do we need to know? The answer is everything. There are two major domains that I think we need information on. And right now, when certainly in the systems which are being overwhelmed, which is like what Lou was saying, we just need to know what we need to gather because, and we can accumulate it after the fact, but we need to gather the basics. And the basics are twofold. One is the course of the disease, and the other is transplant specific issues that we need to go. You saw a little bit of things earlier in terms of the Washington experience regarding what kind of transplant patients were there, but we clearly need to know the differences in outcomes by type of transplant recipient coming forward, lung versus probably everybody else, but we don't know. The time from transplant, the duration and degree of viral shedding or viremia, and in particular, because we've had so much experience with RNA viruses in the past, does immunosuppression prolong either viral amounts and potential transmission of disease or shedding and clearance afterwards? Preliminary stuff looks like it doesn't matter, but I think if we can get any type of information, it would be remarkably important. The other thing is the impact of immunosuppression changes on the course. Are we going to see any rebound infections, induction of antibody-mediated immunity or rejection? What's actually going to happen? And the very important thing is going to be, for those of us who continue to transplant, will the COVID-19 acquisition early after induction immunosuppression alter the clinical infection? There just haven't been all that many done. So as we move forward, the transplant programs, we all need to keep track of this and what type of immunosuppression we use, whether we use depletional drugs or non-depletion is going to be pretty key. The organ availability in donors has been talked about a lot. We do need to make sure that we keep track of what happens to our live donors, that in fact they are okay. We need to know whether there's hospital acquired infections or community acquired infections in this population that's potentially induced by surgical procedures, and certainly deceased donor organs. We just need to know whether there's a risk with the donor and the demographics. The treatment is going to be whatever comes out with the treatments, whether it's the antivirals, the anti-IL-6, the anti-immunomodulators, the anti-malarials, they're going to be done under some sort of IRB. The transplant-specific components will not be part of the standard subset analysis, and we need to know who we have going forward, which goes on it. And with the rise of the use of vaccines, which is something we obviously need, we're going to have an understanding of what the impact of our immunosuppressive regimens are on antibody generation and efficacy, as well as titers. There are just a ton of transplant-specific things that we are going to need to know, that we need to, as the practitioners on the transplant side, make sure we collect this data so that it can be put together into some sort of meaningful accumulation at the end that we can make sense of. The next piece, next slide. The other domain that we really need to know is sort of what's been going on with the transplant-specific capacity to provide specialized transplant care. Will it break down, and when does it break down? As Lou is talking about, the transplant-specific providers will be repurposed to other places, and what's going to be the consequence on our patients and our programs. And as Atul was mentioning, there's a varying phase of performance or non-performance in terms of what goes on after the fact gets done. Understanding what we've done in terms of rate-limiting issues, either self-inflicted or resource external inflicted, we're going to need to have some sort of analysis and understanding. The one which I'm actually quite concerned about is the impact on transplant healthcare workers or professionals, the number that are too sick to care for other people. I think the guys in Italy have seen this happen. There's a fair bit of literature on that, and we're a pretty small population of people. And if we go out, and how many of us do go out for infection or isolation, how's that going to impact existing transplant recipients or the ability to provide care. I think we need to understand a lot of this. We need to keep track of it inside of our own systems, either through administration or through our coordinators, just to keep an issue, because when it's all said and done, we're going to need to understand the impact of what a major system breakdown does to our patients. And I think that's it for right now. Thank you.
Thank you, Tim. Can you guys hear me now?
Yes, we can, Stuart. Thank you so much.
Terrific. Our next speaker is going to be Ashley Morgan, speaking on behalf of AJT. Dr. Kirk is apparently not available, unfortunately. Go ahead, Ashley.
Hi, my name is Ashley Morgan, and I'm the managing editor at AJT. We wanted to let you know what we are doing to support the community during this pandemic. We are accelerating review for all COVID-19 manuscripts. You can see our manuscript types, word limits, reference limits here for submissions. Further instructions are at amjtransplant.com/instructions. Next slide, please. And we are reviewing all formats. All articles are going to be free to access for everyone in the interest of facilitating patient care and advancing science and ensuring that accurate knowledge and experience is available to all during this current time of crisis. We are expediting papers, as I said before, and they will be free access. And they are all collected in one place for easy access at amjtransplant.com/COVID-19. That is updated usually daily, depending on what we have published and what we have ready for readers. And that's it for me.
Thanks very much, Ashley. And I'll just comment that what you're doing at AJT is being mirrored by other transplant-related journals. I do know that the Journal of Heart and Lung Transplant is also working to get COVID-related manuscripts reviewed quickly, and the ones that are accepted posted quickly. There is a separate website there as well. I don't know if there's other specifics, but perhaps we can gather that information from other journals as well. If we have time for one other question, I guess I would ask Tim, recognizing that the data is changing so quickly, how do we understand as a community the data that's coming out here in terms of small uncontrolled studies, and how do we leverage the bits and pieces coming from everywhere to gather information that turns out meaningfully?
Yeah, I think that's a really difficult thing to address, Stuart, because we all have our own individual perspectives. We just did a liver transplant society meeting this morning with lots of different folks from around the world, and everybody has small numbers which are really statistically insignificant by themselves, but the necessity of collating this data is real. Now, whether we can do it through a national system, such as through UNOS, and to set up formal data fields moving forward with certain boxes and ranges of elements that we want to look at, I'm not sure what's available. I don't think we've ever confronted this type of thing before. The societies may be able to help arrange it either through the AST or the ASTS, and we are just in new turf. But unless we at least accumulate important issues regarding what we see and the sequential nature of what we do in transplant, which we all do. I mean, everybody's participated in some form of a trial somewhere, I would think, in which we look at immunosuppression and clinical outcomes and all the different infectious related issues. We can, without prospectively doing it now, we can all sort of keep track of some of that data, and eventually at the end come up with something which may not be clean, but will at least help guide us towards the future.
Thanks, Tim. I guess I'll just make two comments. First of all, I think the group in Seattle is trying to do some of that collection through a local database. And I would encourage all of you to look at that. The second is both AST and ISHLT, and I'm sure there are others, have very active message boards where people are sharing their experience and answering and asking each other questions. I think those boards could also be used for collecting some of the anecdotal experience, and we at ISHLT are thinking about how to do that. I suspect that Emily and her group at AST are doing that as well. And in the short run, using those places may be as quick and easy a way of gathering information as we can get.